All right, well, hi everyone and good morning. I'm John Mcllveen, and I am the State Opioid Treatment Authority for the state of Oregon. So what that is, I work for Health Systems Division, which is out of Salem. Basically, kind of in a nutshell, one of the main things that I do is I serve as kind of the principal liaison for the state and federal regulations and regulatory aspects of what we call opioid treatment programs in the state of Oregon, of which we have 17, 16 of which are licensed by the state and the federal government. One is located primarily on federal government property at the VA in Portland. But I'm also involved with a lot of other stuff involving policy and program issues around opioid use and misuse in Oregon. I know many of you in the room from working on different projects together or talking about different issues, so I'm glad that you can all be here. Work with public health very closely, as well as our Medicaid folks, who are some of whom are here today too, on what we call the Oregon Opioid Initiative, which is a 3- or 4-pronged effort to address opioid use and misuse throughout the state from a multifaceted approach. Now, I'm going to, I lost my clicker. Oh, now I found it. So today, I'm going to talk a little bit about mainly kind of the treatment side of things and try to relate that back to the issue around HCV a little bit. Kind of make some connections around the spread of infectious disease, intravenous drug use, but talk a little bit about the gaps in treatment in terms of OUD. We still have tremendous gaps and difficulties in getting people access to things like medication-assisted treatment, gold standard for over 5-6 decades for the treatment of opioid use disorder. And address a couple other things. I know Dr. Seaman was talking earlier about treatment issues around things, and it's not just HCV, but there are other issues it touches on too, about that link between treatment for other physical health conditions and substance abuse disorder treatment. I think there's been some frustration about that, some of those guidelines for many years. And I would say from our treatment perspective that it's important to note that when we talk about treatment, again, kind of in the context of what I talked about before, this is a multi-pronged effort. Treatment's got to be available, it's got to be accessible. It doesn't mean every single person needs it. It doesn't mean that every single person needs to go, but we need to have it available. Our problem in Oregon right now is that we don't have good availability of it. I think that that's really the most important thing. I think a lot of people, when they hear people from the treatment world talk about this, they talk about treatment, and then everybody has to get, no, should be part of a spectrum of care that's available to folks as they need it. Can I have the next slide, please? Okay, wow, you read my mind. So again, this slide talks a little bit about that background. I mentioned opioid treatment programs. They're the only programs in which folks can be dispensed, not prescribed, dispensed full and partial agonists for the treatment of opioid use disorder. We have around 7,500 to 8,000 of those folks who are in our facilities. I know we're kind of short on time, don't have a lot of maps. Do you have a map? One thing that you would note if you saw the location of where our opioid treatment programs are, most of them are located along the I-5 corridor. I don't have a slide about our state targeted response grant, but that's one of the things that we're doing is trying to expand opioid treatment programs throughout the state. We're hopefully going to have one in Eastern Oregon by the end of next year and one on the Oregon coast, which would be the first one on the Oregon coast. Currently, people drive many times hours daily to access care that's obviously for OUD directly related to their dependence on opioids. Another problem that we've had in Oregon is traditionally one of the lowest rates of penetration, although it's rising in the Medicaid population, as well as accessibility to folks who are able to prescribe partial agonists within an office-based setting. So you hear a lot about data waivered physicians, that's what I'm referring to, or X-waivered. Last year, we had about 467 federally certified folks that could do that work within clinic settings or in, like again, what I called OBOT, office-based opioid treatment settings. We've had some increase in that, up to about 544 currently, which is great. Our biggest problem in Oregon when we talk about access is that for opioid treatment, is that out of that 544, well, I'll use both numbers. In 2016, out of that number, only about 22 to 26% actually ever saw a patient or wrote a script with their X waiver number, which is pretty low. That's increased slightly into the 30s in the 2017 data, but it's still low. I compare it to places like the Northeast, for instance, like Vermont, with their data waivered providers, physicians, now it's MPs and PAs can do the work. They were at about a 70% engagement rate, right around there, so we're well under half of that. So that gives you a little bit of information on that. And just a little bit about our role with that. We don't, the Oregon Health Authority, the Health Systems Division, nor any other division, regulates office-based opioid treatment in terms of physicians that are able to prescribe partial agonists. We do, of course, license, certify, and review opioid treatment programs, and they're required by federal law to offer comprehensive psychosocial interventions, as well as wraparound services, which I think is applicable to this group because we're talking about things like infectious disease. I know a few people, Dr. Seaman and Dr. Kortheis and some other folks mentioned, and actually, I can't remember who mentioned it, but maybe it was Dr. Thomas originally about NAS and prevalence. I just literally got back from doing an OTP site review in Bend, which is currently our only one east of the Cascades, and I literally look through patient records, and that's part of my job, of course, and virtually every single one is HCV positive, is Hep C positive. Virtually every single one. So I can tell you it's anecdote, but I guess it's more factodote, so it's a very, very real issue. And I think when we talk about the link, and I'll talk about that, next slide please, in a few seconds, the link between infectious drug use, HCV, heroin, you probably see in an opioid treatment program setting, you probably see, if you look at somebody's assessment and evaluation, you probably see 75 to 85% of folks, their initial usage of opioids were usually oral prescription opioids, whether prescribed directly to them or used illicitly. By the time they reach treatment at the OTP setting, about that same percentage are injecting drugs. So there is a correlation. As we talk about, and my colleagues from public health and I talk a lot about, there's a huge correlation, of course, between prescription drug use and then advancing to things like IV heroin usage. I would just caution everybody that it's not a purely linear, direct correlation. There's lots of factors involved in it, tons and tons of different factors. Increased availability is one. Heroin's becoming increasingly available even in rural communities in the state at a very high level. Here's a little bit about, so what does the picture of opioid use disorder look like in Oregon? This data comes from our Medicaid fee-for-service population. Obviously it was different in 2005 than it was in 2015 with development of coordinated care organizations and the like. But this kind of tells you it's been a 400% increase. I have some data on the ranges by counties, and I just took the highest and the lowest here for folks to see. Northeastern Oregon, but we have tremendously high rates as well in places like the North Coast, Southwestern Oregon. Dr. Thomas showed before some things from the public health data regarding opioid death and heroin death and opioid hospitalization and the like. And the very interesting thing when you start looking at the numbers is that there's so much synergy in between the highest rates of opioid use disorder, the lowest availability and access to care, the highest rates of hospitalization. I don't think that should be surprising to anybody, but it lines up very, very nicely, although it's not a nice thing, but it's consistent. And remember when I said that it's not a linear relationship between prescription medications and heroin usage, we do have trends. I mean, you obviously, even from the law enforcement perspective, heroin seizures going up 10 times over the last 10 years. There's increased availability of the drug. So that's driving some of it too. Heroin-related arrests have increased quite a bit in Oregon as well. And then you have that self-reported use of heroin at intake in ODOC, a 4-timed increase. So we see it among these populations, and especially, we're looking at populations that are vulnerable populations too, people involved in the criminal justice system, people who are sometimes kind of disenfranchised in general. So we're seeing that, although it does cross socioeconomic lines. Next slide. Put a couple little facts here from a kind of a treatment side, but to sort of integrate the idea of infectious disease and its link with IV drug use and heroin. we still, and it's something we see a lot in the treatment community when I go to conferences or I talk with my colleagues, people say, there's other drugs that are a big problem, and there's no question about that. Something that I think that we have to look at when we talk about heroin treatment, the link, IV drug use, infectious disease, is that, and again, you know, all the data, the great data you saw before about that massive increase in inpatient hospitalizations in Oregon for infectious disease, for infections and infectious related conditions. It all again kind of comes together. The user population is vastly smaller than a lot of other illicit drugs, but it's rising at an almost exponential level, which is something really important to note. This study came out probably, I don't know, about 2 years ago, just looking at the link between infectious disease, HCV, and Appalachia. So those of you that haven't been, you know, living under a rock for the last couple of years have probably seen stuff about the horrible issues that they're having in Appalachia with infectious drug use, heroin usage. It's a self-explanatory correlation. Infectious disease skyrockets with skyrocketing IV heroin usage. So clearly very linked. Now here's something linking it back to treatment and public health issues. It varies greatly. That was a study, it's a couple years old, but I think it was interesting because again, we talk about correlations. I mentioned things like, wow, you know, you have the highest rates of prescribing with the lowest rates of access to treatment, highest rates of hospitalizations and deaths, coordinate with that information. And it's the same way with services for IV drug users. When you have good, robust treatment systems, you have good, robust public health systems, you have lower rates of infection. I know that's nothing that's gonna absolutely shock anyone in this room because it's all your work that you do, but I think it's kind of worth noting. Next slide. Here's a couple of things, and before I go on to this, I want to talk very, very briefly, just for a minute, about some of our federal funding opportunities. We've had something that's called the Opioid State Targeted Response Grant. It's kind of popped into my head. I had a slide, didn't include it here, that details our activities in the grant. But basically, one thing that we're doing that's really directly related to helping to stem the spread of infectious disease is funding for naloxone distribution, needle exchange programs within the Willamette Valley, the Portland area, as well as moving down into southwestern Oregon with some of the areas. I believe, does Douglas County still have the highest HCV per capita infection rate in Oregon, or one of them?
Yeah.
It's up there in the top. So again, one thing that the federal government wants us to do is really target and coordinate with our other partners throughout OHA, but also that have access to different federal funding streams like NIH, CDC. Obviously, our stuff as a single state authority in health systems and health policy is related to all the SAMHSA grants and our block grants that we get for treatment and the like. So that's one of the things we're doing. We're also funding addiction peer navigators in the Department of Corrections system. We're also, again, expanding OTPs throughout the state. So a lot of this stuff is multifaceted. It's very much targeted. Our SAMHSA part of it is very much targeted to increasing treatment access and capacity. But of course, that also has a tremendous impact on holding back, at least, or trying to prevent the spread of infectious disease throughout Oregon. So a couple things statewide and policy-wise over our different divisions and agencies that we're doing to kind of help with the opioid use and misuse issue. House Bill 3440 passed that has a lot of different interesting treatment components, requires drug courts to offer medication-assisted treatment to folks. We're working on development of a little more robust treatment location systems. You also have things like 2355, which is a reclassification of drug laws and the penalties for simple possession. Many of you might know a little bit about that. It's a subject that's not without some controversy among different groups, but in general, a positive thing in terms of lessening stigma and discrimination to folks who have an addictive disorder. And again, I talked a little bit about our work with the Oregon Opioid Initiative with our colleagues in public health. Governor's formed a task force on opioids. What are some things that we continue to need to do? Increased integration of addictions treatment MAT into primary care settings and residential treatment facilities. We're doing that now by doing some rule changes, by requiring folks to both admit people on medications into residential treatment without forcing them to titrate. which is a huge step forward. You know, just as an FYI, one thing that a lot of folks don't know, but is common throughout the country, is opioid use disorder patients have the lowest rate of retention in treatment programs. And you know, we said, why is that? That's kind of a big coincidence, isn't it? Well, it's because most don't offer any type of medication to assist with reducing withdrawals and cravings, which is an important thing to get people to focus on the work they need to do there. Developing better models of delivery that integrate payers and providers, like hub and spoke models, which take on many different forms. I know it's kind of a catchphrase. We do need to continue to engage more with the criminal justice system on things like MAT utilization. That's in prison, jail systems, as well as other criminal justice-based systems like probation and parole, community supervision. Another thing that we're doing with our STR grant is we're funding a county to help to start to induct people on MAT while they're incarcerated, and then try to create a model for continuation of care for those folks at a local OTP. So that's going to be exciting. And of course, greater penetration of naloxone in settings where providers come into contact with high-risk individuals. So all of those are some things, and like I mentioned, that we're doing and that are future directions. And those are some of the focuses in our STR grant as well. I would take, I don't know, Jude.